I have great pleasure in introducing Dr. GURUPRASAD, who heads the Department of Vitreoretina at the famous M.M. Joshi Eye Hospital in Hubli. He's a vitreoretinal surgeon with probably the most experience in our state of Karnataka in matters related to vitreoretina. He will be talking to us about sniffing the enemy, trying to diagnose postoperative endophthalmitis at a very early stage. As we all know, time is vision in matters of endophthalmitis, and how quickly we diagnose also determines how effectively the end result can be addressed. I request Dr. Guru Prasad to please deliver his talk on sniffing the enemy in postoperative endophthalmitis.
Good morning. Thank you very much, Dr. Kumar, for having me in this IC. So, sniffing the enemy, early diagnosis of post-operative endophthalmitis is what I'm going to speak in the next 5 minutes. And after that, the format is that we speak for 5 minutes or a little more, and then the rest of the time is taken up for discussion. So, why should we sniff? Because we have seen that there are fulminant types of endophthalmitis that can destroy vision in a single day. Next one day, the eye can go from post-operative vision of 6/6 to PL negative. The less acute type can go unnoticed by the patient because something that is smoldering inside without any congestion or symptoms can be ignored by the patient, and by the time the patient reaches, the situation is disastrous. Every hour counts. Time is vision is just what Dr. Kumar said, which is so apt. And so we should know how to sniff. We should know how to differentiate between TARS and endophthalmitis. And this is the long list put up there of the differentiating features between endophthalmitis and infective endophthalmitis and TARS. And probably the top three: timing of occurrence, pain as a symptom, and lid edema as a sign are the three most important differentiating features, besides congestion, corneal edema, iris pupil, and intraocular pressure, which is not so important as the first three. Whom to sniff? Well, we should know that we should have a high index of suspicion in patients where they have had a PCR, and even full surgery, a PCR or a retained lens material, long duration versus MDCS, something which I learned recently, minimal duration cataract surgery, which is totally wrong according to me. Iris handling when there has been too much of that, improper wound construction and suturing, vitreous in the wound, exposure of sutured knot, iris prolapse, incarceration of the iris, use of iris hooks or pupil expanders, uveitic eyes, a reaction disproportionate to the surgical trauma, a diabetic patient, an immunocompromised patient, and for that matter, every post cataract patient. So the time to sniff is time to diagnose or look for endophthalmitis is probably day 2, the day after the surgery, day 7, a week after the surgery, and 30 days after the surgery in a normal patient. But when it comes to these risk factors, one has to have a different protocol of regimen altogether. Parameters for quantifying the signs by either clinical examination or by actually documenting or photographing these signs. The cornea can show different severity levels of edema with varying severity. Infiltration of the wound site, as you can see here. Antechamber can show hypopyon and cells like this. Capsular bag can have exudates. Vitreous can have cells and exudates. B scan can show vit echoes, exudates, or lens droppings for that matter when there is a PCR. And of course, retinochoroidal thickening and posterior subcutaneous fluid in a case of severe endophthalmitis going on for panophthalmitis. So, protocol in a case of increased reaction. Whenever we have an increased reaction to the cataract surgery, we have to suspect infective endophthalmitis unless proved otherwise. Intensify antibiotic steroid drops hourly or even half hourly. Decompress the eye twice a day. This decompression is what I'm going to show you in the next slide. If there's no response in 12 hours, then you give intravitreal antibiotics. If there's no response in the next 12 hours, probably you will go for a vitrectomy. So this is what I mean by decompression done on the slit clamp under topical anesthesia. Identify the side port of the cataract surgery and just press on the scleral lip. So, and then you let out the aqueous humor from the antechamber, which releases the fluid from the antechamber, debulks the turbid aqueous, brings in fresh aqueous, clears the cornea and the antechamber, and allows fundus examination, with which you can make a better assessment of what is there behind the lens. So, post-operative follow-up in a PCR, when there is a PCR, for example, you have to do it the same evening. It's different from a routine cataract surgery. I would like to see the patient every few hours. If I have a PCR, I will call the patient the same evening, again next day, again on the third day, and so on and on. I mean, I would like to see the patient as frequently as is convenient to the patient. But I have developed a method by which I teach the patient self assessment of vision every day. The patient himself will assess his vision. It is not the lid edema, congestion, or pain that the patient will be worried should be worried about. I tell this patient to I tell this to every patient when I'm discharging. You should not worry if there is lid edema, congestion, or pain. But if there is loss of vision, then only you should worry. And that is the time when you should rush back to the hospital for necessary prompt action. So this is a chart which I try to sort of give to a patient on a A4 size paper in a printout, or I would even tell him to look at the photographs of his family on the wall of his room, or the calendar, or something like that, from a fixed distance. And this is something that can diagnose endophthalmitis early. So save the eye from being lost to endophthalmitis by teaching the patients the SAVE exercise. This is one message I would like to give here. The self-assessment of vision every day is something which I follow for every patient of cataract or any post-operative case. So ocular sampling is another thing, the anterior chamber tap and the vitreous biopsy that we have to uh, do, and give intravitreal antibiotics or do diagnostic or therapeutic vitrectomy as the case may warrant, especially when the vision and the glow are rapidly deteriorating. So other types of endophthalmitis, the delayed endophthalmitis is something which we have to keep in mind. They come usually 2 to 3 weeks after the surgery. Propionibacterium acne is one organism which can be very, very misleading. It can just appear as a flare up of the inflammatory reaction that occurs immediate post op, and can come back a little later. And this is something that one should be familiar with. It usually causes the breadcrumb like appearance on the posterior capsule or within the capsular bag. Fungal endophthalmitis, especially the candida, can also be similar to the uh, P. acne endophthalmitis in terms of the time of onset, but varies in that the cotton ball appearance is seen both in the antechamber and in the vitreous cavity. And bleb related endophthalmitis can occur anywhere between um, 3 weeks to 30 years after the glaucoma surgery or a combined surgery. So one should be familiar with all these different types of endophthalmitis: the bacterial endophthalmitis, fungal endophthalmitis, endogenous endophthalmitis, and so on. A systemic assessment, I think, is very appropriate to mention here, because that is one thing which probably will complete the talk. Look for signs of septicemia, fever, elevated ESR, blood culture in cases of endogenous endophthalmitis, blood tests like the routine hemogram, renal and liver function test to look for drug toxicity, which can manifest as endophthalmitis, and search for the focus of infection in endogenous endophthalmitis. So, in summary, I would like to say that you should have a high index of suspicion, especially in high risk cases, which I mentioned. Always err on the side of infection. Act swiftly. Exercise save. Save is an exercise, and every inflammation is infection unless proved otherwise. Thank you very much.